We are going to use a cannulated hemi implant, marketed by Vilex as CHI, for the replacement of the base of the proximal phalanx in the first MPJ, damaged by arthritis or other joint disease. The patient experiences pain and difficulty moving the big toe. The indications are lumped into one term, hallux rigidus. Before we begin our demonstration, it is useful to become familiar with the surgical tray and the instrumentation of the Vilex First MPJ system. The kit comes with two types of implants: concave-shaped hemi for the replacement of the base, CHI, and convex-shaped for the replacement of the head of the metatarsal. The phalanx end implants are oval in shape and conform to the cross-section of the phalanx shaft. They come in 5 sizes. They are available in titanium or cobalt chrome with titanium backing for faster ossification. The met heads come in 5 sizes, in cobalt chrome with titanium backing only. The Vilex MPJ implants offer a number of unique features. The stem is basically a self-drilling and tapping screw, requiring no drilling or broaching. The implant is cannulated and screws into the shaft. The driver has 2 prongs that mate with 2 holes on the periphery of the implant. The surgical procedure follows. Make an initial incision, dorsal, medial, dissecting the soft tissue to expose the joint. With a freer elevator, elevate the joint toe. Expose the met head. Remove the bunion and the dorsal spur as part of reshaping the metatarsal head. Smooth the sharp edges with side-cutting burr. Remove the cartilage gradually, starting from the top to expose the trough of the concave surface of the base of the phalanx. Make a cut between 4 to 5 millimeters wide to accommodate the implant and to decompress the joint. The cut should be neutral, perpendicular to the shaft. It is permissible to make the cut slightly slanted, dorsal plantar, to increase the dorsiflexion range of the toe after surgery. After excising the base of the phalanx, expose the base. Select one of the elliptical trial sizers and place it over exposed surface. The implant should cover as much of the surface as possible, with little or no overhang. Once the correct size is selected, run a K-wire through the cannulated sizer. Advance the wire about 15 millimeters into the phalanx and observe how the sizer is seated. It is advisable to use a C-arm to make sure the wire is properly centered. If the wire is not properly positioned, remove the wire and reposition it. This is the advantage of the cannulated system. There is no drilling or broaching, and thus the positioning of the implant is certain to be correct. Advance the K-wire another 20 millimeters. Remove the sizer and slide the corresponding hemi implant over the K-wire and drive the implant with the special 2-prong driver. Since the implant is oval in shape, its initial orientation may be inadequate. Advance the implant forward as much as 1/2 turn for correct orientation. Suture and close.